Hello everyone, welcome back to the PriGina Medical YouTube channel. Today we are going to be discussing about necrotizing enterocolitis. I'll be referring to this as NEC, neck, throughout the slides, so kindly pay attention. We are going to define neck in simple terms. We will talk about the pathogenesis, risk factors, signs and symptoms, complications, treatment, and at the end of the slides we will discuss some USMLE style questions. So first of all, to define neck in simple terms, we refer to it as a GI condition that leads to the inflammation and destruction of the intestinal tract, hence making this disease a life-threatening condition that is high yield for the USMLE exam. So let's talk about the pathogenesis. So neck can occur, first of all, when there is a GI bacteria invasion. So when the bacteria gets into the GI tract, there's going to be gut mucosal inflammation and necrosis, and hence necrotizing enterocolitis can occur as a result. Secondly, reduced mesenteric perfusion from hypotension, example from congenital heart disease, can lead to impaired function of enterocytes. So once enterocytes are not performing well, there's going to be malabsorption of nutrients and also mucosal inflammation and necrosis. And then finally, translocation of gas-producing bacteria into the gut wall, leading to necrotizing enterocolitis. So these are the two main factors that leads to necrotizing enterocolitis. Okay, so now with the risk factors, it's very high yield to know that prematured infants are at high risk of this condition. Why? Because in prematured infants, usually their GI tracts are not fully developed. Also, their immune defense mechanisms are very weak. So whenever there is bacterial infection, they are not able to fight off such infections, hence severe sepsis can occur, and this can lead to necrotizing enterocolitis. Also, it's important to note that term infants can still suffer this condition, especially when they have a reduced mesenteric perfusion from conditions such as congenital heart disease, as described in the previous slide. Secondly, let's talk about enteral feeding. So formula-fed infants are at high risk of contacting necrotizing enterocolitis more than breast milk-fed infants, because during preparation of formula, the risk of bacterial contamination is very high. Hence, these patients are at risk of getting this disease. Lastly, we are going to talk about very low birth weight. So with a weight of less than 1.5 kg or 3.3 pounds, usually such infants will also have impaired immune defense mechanism. Due to that, the ability to fight off infection is very low. So now on to the signs and symptoms. So once there is infection and sepsis going on, there's going to be a spike in WBCs. So as WBCs increase in number, leukocytosis will be seen on lab reports. There is also metabolic acidosis, because once your body is being hypoperfused, your body is going to switch to anaerobic metabolism. And then when anaerobic metabolism occurs, there's going to be a buildup in lactic acidosis. And once lactic acidosis builds up, metabolic acidosis will be reflected on the lab reports. So next is hypothermia. You need to look out for temperatures of less than 37.5 degrees or 97.7 degrees Fahrenheit, because severe sepsis usually causes vasodilation. So when there is vasodilation and increase in blood flow towards the skin surface, there's going to be a drop in temperature. Next on the list is bilious vomiting. So whilst there's inflammation and edema going on in the bowels, there's going to be bile acid backing up in the GI tract, which will cause bilious vomiting. And this can be referred to as green emesis. So when you see green emesis or bilious vomiting, they are the same thing. Again, with the same explanation, abdominal distension can occur with all the inflammation and edema going on. Lastly, there is feeding intolerance, because patient is lethargic and very weak and has lost appetite, so feeding becomes difficult for such patients. Now, the imaging of choice in necrotizing enterocolitis is going to be an X-ray. Therefore, the X-ray findings in this condition are very high yield, and I need you to pay attention to this slide. First of all, look out for pneumatosis intestinalis, which refers to which is as a result of gas leaking into the damaged wall, and then pneumoperitoneum due to air in the peritoneal cavity, as well as portal venous gas. So these are the findings to watch out for in necrotizing enterocolitis. In the next slide, I'm going to zoom this picture so we can point out these findings. Okay, so I will urge you to look at the unlabeled diagram and then compare it to the labeled ones. So with the red lines here outlining the bowel, we are going to see train tract lucency within the bowel wall, which is known as the pneumatosis intestinalis. So right here, you're going to see some dark portions outside the abdominal wall. And then there is another one here, which have been highlighted in red. And then when you look at the liver portion of the image, you are going to see some tiny lines that is coming down the liver surface, which have been highlighted in blue. And this is known as the linear branching gas pattern within the liver, which is called the portal venous gas. So kindly spend some time on this image and make sure that you're able to identify this, because this is a high yield image. So now let's discuss the complications of this condition. So first of all, it's important to note that intestinal perforation can occur leading to sepsis, because when the intestines perforate, they are going to leak their contents into the abdominal cavity, and hence infection and sepsis will occur, leading to a critically ill appearing patient. Next, we are going to talk about DIC, disseminated intravascular coagulation. So an increase or activation of coagulation cascade is going to occur, and then there's going to be a lot of clots forming. So this could even cause a pulmonary embolism, which is a very, very severe complication of this disease. Lastly is strictures and short bowel syndrome, which could be late complications of this condition. So as the body attempts to repair the necrosed bowel, there's going to be fibrosis, and then a lot of scar tissue can form. Hence, the intestinal lumen can reduce in size, and this can result in strictures. Also, usually after surgery, when a portion of the intestine have been removed, there's going to be short bowel syndrome, because the portion that has been taken out has led to the bowel to reduce its length. So that part that has been removed can no longer perform its function. So in these patients, usually they have malabsorption of nutrients. Okay, so I just put in this picture right here to form a summary of whatever has been said in the previous slides. You can take a look at it. It has extra information. If you have time, you can just take a look at it as well. And now to the treatment, we are going to discuss about how to manage a patient with necrotizing enterocolitis. Your first priority is bowel rest, so keep patient nil per hours and discontinue all forms of enteral feeds. Make sure that you have passed an NG tube for decompression of the bowels. Also make sure that patient is hydrated. And then it's important that you take blood cultures followed by broad spectrum antibiotics, because we want to make sure that we are targeting the right organisms with the right antibiotics when those culture and sensitivity test results are finally out. Next, if any form of nutrition is going to be given for a neck patient, make sure that it's parenteral nutrition, where IV nutrition will be given directly into the bloodstream so as to bypass the GI tract, because remember that we always want to rest the bowels. And then lastly, we are going to do surgery if all else fails. So we do a laparotomy, look through the bowels and remove all form of necrosed bowels inside there in severe cases. Example, when there's intestinal perforation like we described earlier, or if patient is unresponsive to medical management. Let's discuss some USMLE style questions that is likely to appear on the exam. So a 6-day-old boy delivered at 38 weeks is brought in with congenital heart disease. Patient also has poor feeding and is on oral baby formula. Patient had green emesis this morning and is noted to have a BP of 63/34 millimeters mercury. Temperature is at 34.8. Pulse is 175 beats per minute. Pulse ox of 82%. Patient looks lethargic and cyanotic, and the patient has abdominal distension and a tender abdomen with absent bowel sounds. There's blood in stool and an abdominal X-ray is obtained as shown above. Remember clearly, we stated that term infants were at risk of this condition, especially if they have conditions that leads to mesenteric hypoperfusion, which could be congenital heart disease. So already we are seeing a term infant here, with congenital heart disease. Patient has poor feeding and is on oral baby formula. Poor feeding or feeding intolerance was one of the symptoms that we discussed. And then patient being on oral formula means that the risk of contamination of formula is high. Therefore, this patient is already having one of the risk factors that was discussed. Patient also has green emesis, also known as bilious vomiting. BP is low and then temperature is low as well. Patient has a high pulse and pulse ox is low. So it's obvious that patient is going to be cyanotic because this patient is clearly hypoperfused. Abdominal distension and a tender abdomen with absent bowel sounds was also seen on physical exam. So we discussed about how abdominal distension could occur in this disease. And then one new thing is absent bowel sounds. So don't be confused if you see absent bowel sounds in any of the questions, because usually when there is inflammation and edema going on in the intestines due to the fluid buildup, there could be a bowel obstruction that could occur as a result. So absent bowel sounds is absolutely normal to see in necrotizing enterocolitis, as well as blood in stool, because you know when your bowel is necrosed, you could also have bloody stools. So please pay attention when you see things like this in the vignette. Always remember that not all questions will give you all the information you need as seen in this question. So whenever there are some parts of the information missing, make sure that you have always ruled out the wrong answers and you always find yourself making the right choices in the exam. Okay, so we know that our answer is necrotizing enterocolitis. Now let's rule out the wrong answers. So intussusception is usually seen in age 6 to 36 months old infants. So such infants, usually they have intermittent crying, and you would realize that they have flexing of their hips to their abdomen whenever they cry. Also, the question is likely to say that a sausage-shaped mass was palpated in the right upper quadrant. And then the imaging of choice here is an ultrasound, which will show a target sign. So none of these were mentioned in the question, so we can easily rule that out. And for viral gastroenteritis, it's usually a benign condition. So you wouldn't see a hypotensive patient who has an abdominal distension or tender abdomen or blood in stool. And usually abdominal X-ray is normal, always normal. So it's easy to rule out this as well. So next question says that what is the best initial step in management? We have IV fluids and keeping patient nil per os, begin enteral feeding, laparotomy, give antibiotics, followed by blood cultures. So if you remember, our patient has a BP of 63 over 34 millimeters mercury. Our main target here is to keep patient perfused. So always make sure that patient is stabilized. So we are going to give IV fluids and keep nil per os, because remember that under treatment, we emphasize that we need to keep the patient on bowel rest. The reason why enteral feeding is wrong again is that we need to give patient bowel rest, so nothing should go directly into the intestine. The closest answer here was giving antibiotics, but then look at the order of the answer here. It says give antibiotics followed by blood cultures, which is the wrong way to go, because we always need to do our blood cultures first. Because again, we need to make sure that we are getting our culture and sensitivity results back. And then that is when we can match the right antibiotic to fight against the particular bacteria that is causing the necrotizing enterocolitis. The next question says that patient continues to deteriorate despite IV antibiotics. Repeat imaging reveals free air under the diaphragm. What is the next best step? So this is pointing to a critically ill patient who is not responding to treatment. So right here, I put in a diagram to show how free air under the diaphragm looks like. So there is a dark portion over here in this unlabeled diagram, which depicts free air under the diaphragm. So when this occurs, it's important to note that this means that there has been an intestinal perforation, which is one of the complications of necrotizing enterocolitis. And if this is not treated as soon as possible, we can lose the patient. So our next best bet here is laparotomy, because we discussed that once all else have failed, we need to call on to surgery. So once surgery coming and a laparotomy is done, the necrosed bowel is going to be taken out so the patient can be saved. Starting total parenteral nutrition is wrong because, again, we need to keep patient on bowel rest. We can't continue IV antibiotics at this point because it's not working. And taking blood cultures again is the wrong answer. So we've come to an end of today's episode. We hope to see you in the next class. Thank you and have a nice day.